work. So that, and Dr. Kandasamy and Dr. Puri have taken that responsibility, and you're going to work. We're only going to work for an hour here. The next hour you're going to be working. So I will be covering in the first part lipoprotein metabolism, inherited hyperlipidemia, short introduction to inherited hyperlipidemia, investigations when you have patients with hyperlipidemia, a little bit on management, case discussion and questions, and the second part will be the severe hyperlipidemia. So, the simplistic view about lipids is about total, you measure the total cholesterol, you look at the LDL cholesterol, and you look at the good cholesterol stage. Often my patients, I want my patients on my side. They always find difficult to remember what is good, what is bad. I tell them this is a lousy one, LDL cholesterol. Tell them that's the lousy one which gives them the problem. That's the happy one which is good for their heart. No, the lousy one should be low, the happy one should be high. People understand better. If you go and say this is low density lipoprotein, high density lipoprotein to people, they don't understand that, they don't work with you. This would be a very good one to tell your patients. And often my patients come and ask me, what's my happy one, what's my lousy one? And they know the lousy has to be low. Right? So the LDL cholesterol, you know, it's all associated with ApoB protein, and a simplistic view is that it carries cholesterol to the peripheral tissues, and it aids in the formation of the atherosclerotic plaque formation. The HDL, on the other hand, ApoE1 is the carrier protein for that, and it carries the excess cholesterol from the peripheral tissue back to the liver. Let's advance a little bit on the different lipoproteins, because that's not really the lipoproteins that are circulating in the blood, and you need to know a little bit more to understand the inherited hyperlipidemia. So, what are the lipoproteins? When you measure your total cholesterol and triglycerides, it's a summation of many of the lipoproteins. And what are they? The first one is the chylomicron. I'm sure you've started making these chylomicrons now that you've had your breakfast an hour or 2 hours before. Now you're making these chylomicrons absorb the fat and making the chylomicrons in your intestine. It's the largest, lowest in density it floats because of the high lipid content, very much less in chylomicron. The VLDL, you make it in the liver, and the you're not measured in your triglyceride. VLDL gets measured in your triglyceride because they're triglyceride-rich particles. Then you have the intermediate density lipoprotein, which has more cholesterol than these particles, and it comes from the VLDL, and then the LDL, which you are very familiar with, and the HDL, which you are very familiar with. HDL has less lipids and more proteins. So these are the lipoproteins that circulate in your blood, depending on whether you're in a fasted state or whether you're in a non-fasted state. In a non-fasted state, chylomicrons, there will be lots of chylomicrons, depending on what you need. I think with Indian food, good, rich Indian food, you should have lots and lots of chylomicrons floating in your blood. So let's see how are they different, these particles. So this is a proportionate, sizes are proportionate. The chylomicron is the largest particle. The VLDL, IDL, LDL, and HDL is the smallest particle. And if you look at the major proteins associated with these proteins, because the ApoB carrying proteins are heterogenic. So you can see we have more heterogenic proteins in the cholesterol, in the circulation than intermediate density lipoprotein, and you make peripheral tissues. Lipoprotein little a is another LDL-like molecule which has got an ApoE protein which resembles plasminogen activated inhibitor. So it cheats by the system by showing that it is a clot lyser but doesn't function as a, and therefore having a high LPA is your risk for developing protein little a to assess the overall cardiovascular risk. So it's quite a useful measurement, especially if you think the cholesterol levels are low, high risk for cardiovascular disease. I'm a chemical pathologist, very interested in the laboratory, and therefore we can separate these fractions using the property that they differ by their density by a technique called ultracentrifugation. But you can't have an ultracentrifugation test done on a daily basis, but there are different techniques, NMRs and so on, which can differentiate this in the present day, and you can get the profiles done. But it's not an easy investigation. That's why most often we only measure a total cholesterol, LDL cholesterol, HDL cholesterol, and triglycerides. Do you measure LDL cholesterol? Calculate? How do you calculate? Do you all know the calculation for LDL cholesterol? Good. So there are lots of apolipoproteins, more and more being discovered. So they're associated with the different proteins, but at least know that ApoA1 is associated with HDL, ApoB100 is associated with LDL cholesterol. There is an ApoC2 which is associated with chylomicrons, VLDL and HDL. ApoE associated with chylomicrons, VLDL and HDL, and ApoA5 again associated with these. And it's important to remember these because you will see that some of the cases we discussed may have relevance to those. Okay. So just going through the chylomicrons synthesized in the small intestine. It transports your dietary lipids. This is the venous lipid pathway. 98% is lipid, large sized, and the lowest density. The a protein associated with this is ApoB48, unlike the VLDL and the IDL and the LDL, which is 100. It also has ApoC2. The reason why you need an ApoC2 is because the lipoprotein lipase, an enzyme which hydrolyzes the triglyceride, needs ApoC2 as an activator. So it has to be associated with chylomicrons. ApoE is also important because this functions as a ligand for you to take the chylomicron remnants to the liver for metabolism or chemicals. So the chylomicrons, the nascent chylomicrons with the ApoB48 acquires the ApoC2, ApoE, which are important in the metabolism of the chylomicron pathways. On the other hand, the endogenous pathway, the VLDL is the product. The nascent VLDL, which is formed in the liver, has the B100. Again, it's associated with ApoC2 and E because lipoprotein lipase has to remove the triglyceride from the VLDL to form the IDL and LDL. So you need the lipoprotein lipase. You need the lipoprotein lipase, you need the C2. Yeah? So that's simple. When VLDL is acted upon by the lipoprotein lipase. It forms the intermediate density lipoprotein. 75% of the ideal intermediate density lipoprotein, which is also an atherogenic particle, is cleared by the liver. So if you make more VLDL, if you provide the substrate by heating a lot of fatty food and triglycerides, you're going to make more VLDL, and that is the basis of the high triglycerides in patients who have a high waist measurement, obesity, and so on. 25% of the intermediate density lipoprotein is converted by the hepatic lipase into LDL, which we all know about. And that time it loses the ApoE to the HDL, and you don't have ApoE in LDL, or the LDL. That's the only molecule which doesn't have ApoE is the LDL molecule. The intermediate density lipoprotein I have explained to you that it comes from the VLDL. Looking at briefly the HDL cholesterol. HDL cholesterol is well known for the reverse cholesterol transport. What it does is it goes to the periphery, the nascent HDL, which is a disc-shaped one, doesn't have any lipids, and it avidly takes the lipids from the peripheral tissue. And it becomes bigger and bigger and becomes spherical to be taken into the liver for removal of the excess cholesterol and ester. So this is why the HDL is very important in prevention of atherosclerotic clot, because it removes the lipids from the periphery. So that is the function of the HDL. HDL is just not removing the excess cholesterol from the periphery. It also has other functions. Although we don't know enough about HDL and we don't have enough to target HDL, it's a well-known molecule for a pleiotropic function in the body. It prevents adhesion and migration of the monocyte. It prevents the chemotactic proteins. Prevents the oxidation of the LDL and endothelial function. It's important for the endothelial. So there are several HDL functions which are important in preventing atherosclerosis, and that's why it's considered a protective molecule. So what are the important enzymes which you have to know a little bit about? This is lipoprotein lipase. I did allude into lipoprotein lipase a little bit, which is important in the hydrolysis of triglyceride-rich particles. Hepatic lipase. This is the LCAT, lecithin cholesterol acyltransferase, which removes the excess cholesterol from the peripheral cells. ACAT, the acyl-CoA cholesterol transferase. We have shown a big interest in these enzymes in the laboratory and in research, but we haven't moved forward in getting a drug which can target LCAT or ACAT, although there are lots of drugs in the pipeline looking at these pathways as well. The next enzyme in the lipid pathway which you have to know is the cholesterol ester transfer protein, which is in the plasma, the CET. So, little bit about lipoprotein lipase. Again, all this is, there's enough of that in your notes. I won't go through each one of that, but remember that lipoprotein lipase doesn't function on its own. It needs an endothelial cell protein called GP1, HBP1, which transports the lipoprotein lipase to the capillary lumen. So, if that is not there, this is not going to function. Okay? So I want you to remember that. It attaches to the surface of the capillary endothelial cells by, again, heparan sulfate proteoglycan. Again, heparan sulfate proteoglycan is important for the function of the lipoprotein lipase. And it needs apolipoprotein C to be functional for the catalytic part of the lipoprotein lipase. You need the apolipoprotein C2, which functions as an activator. ApoE5, again, I'll go through that slightly more in a detail when we go through the next part of the lecture, required for the hydrolysis of the triglyceride LDL. So LDL needs lot of help from all these. GP1, HBP1, apolipoprotein C2, and ApoA5. So all these important for the proper functioning of the lipoprotein matrix. Hepatic lipase, synthesized by the hepatocytes, mostly involved in the HDL metabolism. So if you don't have enough of hepatic lipase, which can happen secondary to some diseases, it results in a triglyceride-rich HDL and VLDL remnants. And it's associated with increased CVD. LCAT, what it does is to make the spherical HDL into a mature LDL. That is, it takes the free cholesterol and it makes into cholesterol ester and puts back into a mature LDL. And so that's the function of the LCAT. ACAT, again, we know that excess cholesterol is stored as cholesterol esters. The conversion of the cholesterol to cholesterol esters is catalyzed by this enzyme ACAT. There are in pipeline ACAT drugs targeting ACAT for reducing cholesterol. We hope there's one which is failed and has been withdrawn, and I'm sure there are drugs which are being worked out for as a target, ACAT as a target. So it's good to know these names and what the functions are, because in future you may see some drugs coming out with targets as these enzymes. The cholesterol ester transfer protein, we've been successful in getting a drug which works on that. And what it does is it facilitates the transfer of the cholesterol ester from the HDL particle to the LDL and the VLDL particle. So what you want to prevent is this process. So you don't want the cholesterol ester from the HDL particle to go into the LDL and VLDL. And there are inhibitors of CETP being developed, which are now used as an adjunct for cardiovascular risk prevention to increase the HDL concentration. The Pfizer drug has been withdrawn. The tolcetrapib has been withdrawn because it had an off-target effect of raising the blood pressure, and more people died in the treatment arm than the placebo arm. Then the Roche developed another drug, dalcetrapib, and they thought it doesn't do very much, and so they withdraw that. There's one drug which will be completing a big study, the HPS trial, which we expect to see the results next year using anacetrapib, marketed by Merck Sharp, and we hope that that would become a drug which would help us to increase the HDLs. And this is what it does. So there's the CETP, which normally exists, which transfers that. We are inhibiting that, so we increase the HDL concentration. And I'm sure Dr. Puri will be going through these drugs in his lecture, and you will hear more about what it does and what are the trials so far and so on. So at least you understand the basics of these drugs. And CETP activity is important, and clinically as well it's important for you to think about. High triglycerides, it's a common problem in the Indians. There isn't an Indian who has a normal triglyceride at all. So it's they call us the lipid tetrad or triad, which is always associated with a high triglyceride and high lipoprotein, literally slightly raised LDL and so on. So people who have high triglyceride always have a higher CETP activity, because you need to take these cholesterol ester to the VLDL and LDL, so they have higher quantities of CETP. And when you have higher quantities of CETP, when you have to transfer the cholesterol ester from the HDL to the LDL cholesterol, the HDL becomes smaller and you make more small dense LDL. So it's a very important enzyme which which does a lot of bad to us if you have in high quantities. And inhibition of, at least for the present time, looks that we're going to benefit from that. So, as I said, it has additional benefits. And there is also recently some evidence having a high HDL is just not protective. You should have a functioning HDL. There's a dysfunctional HDL, therefore it doesn't do its function very well. And you will think there is a lecture on that as well, dysfunctional HDL, if I remember. Maybe someone will allude into the dysfunctional HDL. And even if the HDL is high, it has a decreased cholesterol efflux capacity, reduced antioxidant capacity, and reduced anti-inflammatory activity. And it's very difficult to measure the activity, the functional activity of the HDL. And probably as we discover ways of measuring the functional aspects of HDL, we will learn a little bit more about it. It's still in the laboratory, in the research laboratory, but not on routine practice. So now that you have got a basic understanding of the lipoprotein metabolism, you have any questions after this? Can I go on to the inherited hyperlipidemia? Proceed on to that? Very quiet audience. I hope you don't keep quiet for the second session.
Can you elaborate more on the defective HDL? That HDL goes up alcohol, is that something that you want to?
Defective, sorry?
The defective HDL.
Okay. Defective HDL, it can be acquired or secondary. There are some hyperalpha lipoproteinemia where HDL is very high, and I don't think we know very much about it other than that, in the laboratory we have techniques to find out whether it has less oxidizing, antioxidant effect, less nitric oxide producing effect, and so on, less cholesterol, reverse cholesterol transport activity, and so on. And there is also some doubts whether by increasing HDL, by becoming bigger HDL, whether the HDL that we increase by CETP inhibition is entirely a functional one. And I think we have to wait for some more studies to find out whether that is true or not. And unless the laboratory sorts out that technique, even in UK, we only have 2 laboratories which do the dysfunctional HDL measurements. So, if
this HDL goes up with alcohol, this HDL then goes up when you take alcohol.
I don't that is true. It doesn't not entirely, but it's possible that it loses its antioxidant capacity when you drink more than that is necessary. So some of that may be non-functional HDL. Just having a 2.5 HDL by having 40 pints of beer or 40 units of alcohol may not be good, even though your HDL is 2.5. Okay, let's look into this is the Fredrickson classification. You have it in your book, and I thought this is a really, really good slide. I know it's a little bit difficult to understand, but you do have this on your handout. This is the first one, the hyperlipoproteinemia, the type 1 familial chylomicronemia. Now we understand why we need to understand the basics. Chylomicrons alone are increased in this, and it's a monogenic disorder, which means a single gene, which is related to LPL or the associated proteins which are necessary for the function of the LPL is defective. And always the patients present in the young age, children, adolescents or early in life, chylomicrons. And the risk associated is pancreatitis. The type 2A, which everyone is now very familiar with because there is lots of awareness about familial hyperlipidemia, where just LDL is increased, monogenic, again, LDL receptor defect, ApoB defect, or PCSK9 defect, and we'll have a whole session on familial hypercholesterolemia tomorrow, and maybe I'll touch upon homozygous today. The two things, I find this very difficult to differentiate, especially in an obese patient who has familial hypercholesterolemia. So the type 2B patient, there is a familial element. So if you take a family history, it will look as if they have a pseudo dominant, autosomal dominant inheritance. They have a high VLDL and LDL, so the total cholesterol and the triglyceride are increased in these patients. The only way you can differentiate from the secondary causes is by ruling out the secondary causes and then looking at the family history and so on. It's polygenic and becomes very difficult. You can't do a genetic test on this. Multiple etiologies, even genetic. Type 3 hyperlipidemia, the intermediate density lipoprotein or the chylomicron remnants are increased, and they have to inherit an ApoE2 4 and 5, again, increased VLDL and 4 in the chylomicron. So there are 5 times. When you're a lipidologist, this becomes useful. Otherwise, it's good for the examination. You know, MD examination always has questions on the status and classification, or your professor may ask you questions relate to that. So, but if you want to practice lipidology, you need to know, because you need to be able to ask for the genetic test for the particular one when this becomes really useful. How did they come up with this classification? The Fredrickson worked in the lab in a biochemistry laboratory, and he himself ran the electrophoretic strips for these patients, different patients, and he showed that which are the lipoproteins which are increased, and it also showed this shows the relative frequency in the States. I don't think I have the relative frequency in UK or India, but some data from US is available. So let's look at the lipoprotein lipase deficiency, the first, the type 1 hyperlipidemia. Here, as I said, chylomicron remnant, and chylomicron remnant to be taken up by the liver. If you don't have lipoprotein lipase, all your chylomicrons, which come after eating, are going to stay in your circulation. Same way, lipoprotein lipase is also essential for the VLDL to be converted into LDL, and therefore the VLDL concentration will be high, and the ideal concentration can also be high in these people, and the LDL will be low. So they have very low LDL levels, but they have high triglycerides, and that's why lipoprotein lipase deficiency, inherited problem, always presents with very high triglycerides in the young, and continues to their adulthood with recurrent pancreatitis, because the chylomicron particles are so big, and it's believed that it goes through the pancreas and it gets digested. It's a self-digestion in the pancreas, and therefore they get pancreatitis. And they're often present with eruptive xanthometer, and they look like that. I don't know how many of you have seen patients with eruptive xanthometer. It can also be seen with hypertension, with the uncontrolled triglycerides, when you have a lot of chylomicrons. They usually present in childhood. Massive hypertriglyceridemia and hyperchylomicronemia, recurrent pancreatitis, extremely low or absent activity of LPS, eruptive xanthometer, and if you see a patient with 2000 or 1800, look at the fundus, you will see the lipemia retinalis, which is again a sign of high triglycerides, and they often have hepatocellular regulation. So don't ignore patients who have lipemia retinalis and hepatocellular, because they it's just not deficiency. Cholesterol levels 190 milligrams per deciliter, autosomal dominant and premature vascular disease. So that's again an important one which you shouldn't miss at all, because if you have a patient with familial hypercholesterolemia, you can protect the family, because every sibling, every all children have a 50% chance of having a heart attack. There's no use to waiting for the young ones to get a heart attack to make a diagnosis. Don't wait till they go to see the cardiologist. Please do the intervention much earlier, and therefore it's very, very important to recognize this problem. Type 2B, as I said, this is really mystifies me as well, whether to label it as familial combined hyperlipidemia or otherwise, whether they're fat, because familial combined hyperlipidemia, the only way you can differentiate is the familial nature. Other than that, it'll be a mixed hyperlipidemia in a fat, insulin-resistant patient. So if there is a family history, I label them as familial combined hyperlipidemia. Otherwise, don't. This is these are the tendon centimeter. You will see the Achilles tendon centimeter, the extensor tendon centimeter, and the premature corneal outcast, all hallmarks of the familial hypercholesterolemia. So if you look in your handout, there is a diagram which I drew myself because my daughter refused to help me. So it's not good graphics, but it will tell you the whole. It's a stick man which tells you how to examine a patient with lipid problems. If you start from the top, look for the corneal outcast, look for the sample S matter. Listen to the carotid for the carotid bruit, abdominal, again renal artery bruit, femoral bruit, and then look for soft tissue tendon centimeter behind the elbow, palmar xanthoma in your palms, extensor tendon xanthoma in your hands, and then again Achilles tendon and the tuberous, the eruptive xanthometer on the top. So these are the things you're looking for when you're examining a patient who has hyperlipidemia, and it's important not just to look at the lipid profile and say he has high lipids. Please examine, look for lipid stigmata, because they tell you a story and that will help the family. So that's very, very important for you to look for lipid stigmata when you examine your patients. So type 3 hyperlipidemia, again, not uncommon, especially it's becoming more and more common because the lifestyle is becoming worse and worse. But you can see McDonald's, KFC, all that have landed here. It's going to become, the prevalence is going to become even higher, because that's, I was telling Dr. Puri, this is a poor man's food in UK, but here it's a rich man's food, Kentucky, because poor people can't go and eat in Kentucky. So it's going to be a bigger problem for us. So how do you recognize them? Equimolar increase in cholesterol and triglyceride, accumulation of the chylomicron remnants. Now, ApoE2, the apolipoprotein 2, is important as a ligand to carry the chylomicron remnant to the liver. So if you don't have ApoE2, the lipoprotein lipase hydrolyzes the triglyceride, and after that, this big particle is taken to the liver by the ApoE. If the ApoE is defective, it cannot attach to the liver, so you're going to have lots of chylomicron remnants in the circulation. That's what happens in type 3 hyperlipidemia or bis beta lipoproteinemia, which we call. So the normal form of there are 3 isoforms: apolipoprotein 2 and 4. 4 is associated with Alzheimer's, some association with Alzheimer's. 3 3 is the normal one. Majority of people carry the apolipoprotein 3. They're only different by the amino acids within that protein. So you have amino acid cysteine at 112 position and arginine at 158 position. If you swap this arginine for a cysteine, it becomes 2, the defective form or the mutant form at 158. So if you inherit, it's a recessive form, and if you inherit a 2 from your father, 2 from your mother, and you get a 2-2 form, it cannot clear your chylomicrons, and that's when you have a type 3 hyperlipidemia. People present, this is one of my patients who had type 3 hyperlipidemia. As I said, sample as matter, big sample, and I'm sure it's not an uncommon finding. People present with sorry about that. I should have put that other one first, but it's 270 to 470 cholesterol, 450 to 1800, triglycerides, autosomal recessive condition, more common in men. Women, there is some protection with the estrogen, and rare in children, because children are really good. They run around, they don't consume alcohol, they don't put on weight, because you do need a second hit mechanism for you can have the genotype, not develop the condition. If you're really good with your lifestyle, you would never be diagnosed with a type 3 hyperlipidemia if your lifestyle is perfect. If your lifestyle is bad, that's when the second hit goes, and then it expresses itself as a genetic and a phenotypic presentation. So in essence, this is the lipoprotein metabolism. The intestine, this is the exogenous pathway, chylomicron, remnant. This is what goes up in type 3 hyperlipidemia because you don't have the ApoE to take and IDL. This remnants also need the ApoE, and because ApoE is not present to take it to the liver, these fractions will also be high in the circulation. That's why they present with high triglyceride and high cholesterol. So why treat lipid levels? The 2 important risk factors, vascular disease and acute pancreatitis. So how making it really simple. What are the patients we see in the, when you see a patient, how should you think about it? So patient presents with a high total cholesterol and high LDL cholesterol, high total cholesterol, LDL cholesterol and triglyceride. That's a combined hyperlipidemia. This will be isolated hypercholesterolemia. High triglyceride and the cholesterol is not interesting at all. It's normal or below normal. And you may have HDL with or without lipoprotein little. It's not as complicated as cardiology. You don't have to know the electrophysiology. You don't have to think about the valvular problem. Lipids are easy. You can master it. So these are the only patients you're going to see. That normality is only going to be seen. So when a patient comes and sits with you in front of you, think of those. Put them into one of those boxes. What is that normality they have? Are you looking at a primary prevention or a secondary prevention? Primary prevention, people who haven't had any episode, including pancreatitis. If you're talking about triglyceride, pancreatitis, if they haven't had a pancreatitis, it's primary prevention. If they had a pancreatitis, that becomes secondary prevention. So decide whether you're dealing with primary prevention or secondary prevention. Secondary prevention needs more aggressive management. Primary or secondary hyperlipidemia. Primary is all the genetic problems. So from these, you need to be able to decide whether they have a primary problem or a secondary problem. The primary problem and the secondary is usually due to a risk factor like diabetes, overweight, hypothyroidism, liver problems, primary biliary cirrhosis, nephrotic syndrome, all the causes of secondary. So what do I do when I see a patient in the clinic? What are the investigations I do? For any patient who comes and sits in front of me, I always urine dipstick because they may have nephrotic syndrome. liver. Simple test, picking up a protein in the urine. Not expensive, so I don't want to miss that. And I always do a urine testing. So in my lipid clinic, the nurse would have done a weight in the eye and would have done a urine dipstick, where again tells me that it is low. And if there is a he is diabetic, you may pick up it in your clinic, and that's the indication that he is diabetic. I always have a urine test there. When I get the referrals from the GP or secondary care professional, I always repeat a fasting lipid profile, believing that the GP would have made the lifestyle changes and would have improved. So I do a repeat fasting lipid profile. I do after 10 to 12 hours of fasting. Do a fasting blood glucose. Now you can do a glycogen hemoglobin instead of glucose because it's now more diagnostic. Liver function test, because I don't want to end up with a primary biliary cirrhosis and a high cholesterol. I'm missing that. Renal function test, again important. Again, renal failure associated with lipid problems. Thyroid function test, hypothyroidism. I always do a creatinine kinase because you may have some patients with a high creatinine kinase, and you may do it later on and find that it is high. So I always do a basal creatinine kinase, especially if I'm going to consider a combination therapy for the patients, and therefore I do a creatinine kinase. I don't know whether your practice allows this many tests, but this can't be that expensive. Be aware that high level of triglycerides, anything about 20, which has a lot of chylomicrons, will give a falsely low sodium measurement. So if you get a low sodium measurement in a patient who has high triglyceride, that's called a pseudo hyponatremia. Yeah, pseudo hyponatremia, because if you take plasma, most of it is oil. You measure sodium in the water phase. So the machine picks up 100 microliters, half of it is oil. Oil doesn't have any sodium. And so if triglycerides, if you see a low sodium, ask your laboratory, if they have a blood gas machine, it will give you an accurate value for the sodium. Some of the measurements in your lab may be falsely low. So what are the special, if you're a lipidologist, what special investigations do you have? ApoA1 and ApoB, because ApoB, if you do, you don't need to bring the patient fasting. You will know the atherogenic particles because it's IDL, the LDL, and the chylomicrons, the remnants, all these carry ApoB. So that can give you an estimate of the atherogenic protein. ApoA1 for your HDL. Lipoprotein level A, I didn't say. We do a test called floating beta test, which is I think the Lipid Association should also have a few biochemists here so that they can develop the laboratory support for you all, because if you have so many lipidologists come, you need the support for the laboratory. So you do need a good laboratory. I did say that in type 3 hyperlipidemia, there is an increased concentration of chylomicron remnant. Okay? So the chylomicron remnant behaves like chylomicron when you do the ultracentrifugation. And when you do an electrophoresis, it behaves like an LDL. So what we do is we ultracentrifuge the sample, we take the floating part and we electrophorese, and it moves in the LDL region in between the LDL and chylomicron, and that's the floating beta test. You can measure the post-heparin lipolytic activity if you suspect lipoprotein lipase deficiency. ApoC2 can be measured. You can genotype ApoE, 2, or 3, or 4, whatever that is. And you can also beta quantification by ultracentrifugation. You can measure how much of chylomicrons are present in the thing, and then mutation screening for the different hyperlipidemias. So family history, there's a family history of cardiovascular disease, arrange family screening if appropriate to the clinical history, control secondary causes, lifestyle change is very important. Approach can be, depending on the cholesterol, you can say how low fat. Some of them may have to go for a low fat diet as low as less than 5%. If you have blood protein lipase deficiency, the patients will have to go for a diet which is less than 5%, 5% of total fat in the diet. The drugs, I'm not going to go into details of the drugs, but lipid-lowering medications, which are for triglycerides, and I'm sure in the next 1.5 days you will hear lots and lots about these. And you have the different modalities for treating these lipids. And again, this is lipidology on one slide, and I tell my GP they could have this in front of them and could practice lipidology to some extent. So you divide your patients into isolated hypercholesterolemia, combined hyperlipidemia, isolated hypertriglyceridemia. First line treatment is statin. Patients not tolerated higher doses of statin switch to lowest dose of statin and add ezetimibe. I'm sure ezetimibe is available as combination therapy here. We don't use combination therapy because it's very, very expensive for us. UK is, people might think UK is rich, we have a big ration in NHS, so we have to use the two drugs separately. Higher dose and not always refer to something to do with that. There are new drugs, bile acid residues, which are difficult to manage, and therefore it's better to refer to a specialist opinion. Again, here the first line treatment will be statin, and then you can add any of the drugs, because here the cholesterol is high, the triglyceride is high, the statin reduces the triglyceride by 20 to 30%. So give the statin first, unless the triglyceride is over 1,800, where you would also give the triglyceride lowering along with that. We do use a bit of omega-3 acid ester, fibric acid derivatives. Nicotinic acid may be available here. We don't have nicotinic acid back in the UK, so we don't use nicotinic acid. We have to import from Europe if we have to use after the HPS, which reported that it has no side effects. Isolated high triglycerides, your triglyceride lowering drugs to be used. So that's management in one slide. I think I should stop and we should go for the clinical cases rather than Dr. Rees. Any questions? I think I may have reached my time. It's 11. So that's why I thought I'll stop there. Any questions? You want to? Do you want a mic, Nandini? Interesting finding. I always say, we get referred really bad ones. I have nearly 10 lipoprotein lipase deficiency. So all these patients very difficult to control, and they always get triglycerides in the.
So you know that the first line of investigation you have to look for creatinine kinase?
No, not first line. In the investigation, I always do the basal creatinine kinase, especially if I'm going to give combination drugs, because muscle pain, people complain of muscle pain all the time and they stop the treatment. So if I have a basal, at least I can argue with them that it was 300, it was 400 before I started, so it can't be your creatinine kinase. And great, isn't it? There is nobody, with Alex in it. But I don't know how it is here. In UK, people read the leaflet within the tablet listing, and they say muscle pain, and it all becomes bigger and bigger after they read it. It's actually the tablet insert syndrome rather than the real pain. So that's why I always do a creatinine kinase. I don't know how easy it is for you to get a creatinine kinase here as a big, but you don't need to do on all patients, but if you have complicated cases, if you're practicing as a lipidologist, perhaps that's important.
What you do with these muscle pain cases, then what is wrong with insert tablet or this? What do you really do then? Do you use metalastatin or what is your experience with? Or do you decrease the doses?
We decrease the dose. We have patients on alternate days. We have once weekly dose. We give ezetimibe, and you will hear from Dr. Puri tomorrow, I think. There are wonderful drugs coming out for the statin intolerant patients, the PCSK9 inhibitors. So, and I think there is a statin intolerance talk as well tomorrow.
You use once weekly.
Then I may do HCR. I don't regularly do HCR. Again, it's inexpensive. So, for us, 90% of the people are funded by NHS. So we are with those special cases. It's not for everyone. It's not for a genetic test. It's not for everyone.
Hello. In terms of people who are getting pain from the statin, one of the things I found, like the gentleman said, is the thing. But if this is the outside or outside, it's probably not from statin. Because many of them, as you said, are older, that's when they take their cholesterol medicine. So having everything to be blamed on statin. So that's not easy to do. Other thing we use is CT10. We use CT10 for
We don't use secret lens. We don't measure secret lens.
No, we don't measure it, but
Oh, you use it in
yeah, when people are complaining of weight symptoms.
secret lens is available over the counter.
Yes.
So people say, I want to take secret lens, I say go and buy.
Yeah.
That's taking stores, but I don't think there's enough evidence for us to say secret lens that's reduced my body. So most of the papers and the website say to get secret lens or the transdermal for steroids.
And also, there's a lot of things. Alcohol is another thing. If they have alcohol, they have high fat, cholesterol, and triglycerides, and don't give them statin. Also has a muscle. Like you said, they can put this in the cycle.
I think we should stop cases. So it's the audience going to work, I'm just going to put up, and if you don't talk, Dr. Puri is going to get up and ask questions. This patient was seen by the GP, prescribed and retired from 12 years ago, seen by a GP trainee. He had itching on the thumbs and upper arms, prescribed antibiotics, no response to antibiotics. The senior GP measured the lipid profile, and that's what it is. Looks gross, isn't it? How many of you have seen such high levels? think Dr. Lead the discussion. Do you want the profile again? Nephrotic syndrome. Anything else? Glucose. What simpler? Yes, thyroid. So you want to roll out secondary causes first. So what are the secondary causes which can give rise to combined hyperlipidemia? Thyroid, diabetes.
ये तो लाइव में इसको इंटरनेट भी आ रहा है
Nephrotic syndrome. Cholestasis. So these are these things to do. They're not expensive tests, are they? So you don't want to miss that.
Absolutely.
Hello? Are you taking any medicine or what was the BI especially? What is very
good? That's yeah. Ask questions, yes. If you want to know the BMI, BMI is 30. What do you want to know? Syndrome or frank diabetes maybe, isn't it? Frank diabetes maybe, isn't it? So let's see what they did. So that's the lesion for which he was given an antibiotic. So don't miss that. I know it's a Caucasian skin, but it may be slightly more difficult, I suppose, in asking to see that clearly. But I'm sure, I don't know, lipidologists here would confirm, because I left India when I was here, complex lipid problem. Do you see such erector centimeter here? You do? And they look just like this. And there you are. So no doubt the GP thought it is an infected lesion and gave the antibiotic. Patient was started on triglyceride for a week, and if he had pancreatitis, that GP trainee would have been in. When will you worry for pancreatitis? I think 1,500. Sorry? 1,500. Which one do you think is responsible? Which lipoprotein gives more pancreatitis? Right. Which lipoprotein fraction? Chylomicrons. So most often you have to have the chylomicrons in the circulation for them to have the pancreatitis. And you will see the
mechanism of pancreatitis.
They say that these big particles go and block the arteries, and it starts an inflammation there. Because pancreas has the lipase in it, it autodigests, it just breaks down and it autodigests this thing, and they develop pancreatitis. So that's the fundus. That's important. Don't go for expensive investigation. These are more important. Lifestyle. Alcohol. And high-fat diet. Physical activity. Yes, minimal. I was discussing with, because Rashmi and me were putting this together. I think I can say it, and somebody was just told, no, don't do it here. But I can, because I'm going to fly away. I can do. That's a policeman from UK who stopped work 1 year ago. So very active until then. So he was not exercising at all. But Rashmi is saying maybe it's more appropriate for a working policeman here rather than a retired policeman. So, and I think that might.
Madam, working policemen in Calcutta, in Chennai, and Bombay, they are the high incidence of metaphysics.
Exactly. This is because in UK, because they stop all the exercise, they stop all the activity, and for a year he has not been exercising. I don't think it's atherosclerotic. It's atherosclerotic disease. Yeah. I don't. Okay. Oh, here. Okay. So he was on a high-fat diet. Physical activity was minimal. Ruptured aneurysm, and so he wanted the medication. There you are. He was on metformin 500 milligrams per day. Smoking. The GP started him on metformin. He was smoking 7 cigarettes. Does not consume any alcohol. Next step. Next time it has to be better. I think next time what I'm going to say is, we will ask Dr. Puri and we will ask you to bring the cases, and that would be the best way rather than like, because nobody is. His triglyceride increase was due to the type 2 diabetes, obesity, little bit from smoking, no alcohol or drugs he was taking, which adversely affects lipid profile. Always, when a patient comes and sits in front of you for any lipid problem, consider the risk factors. Consider the risk factors, especially medication. We can scale them. As specialists, you can scale them. I am sure that the cardiologist to lose weight than the general practitioners. He's a very Dr. Will you tell me to stop then? Yeah? We can go. So that's very important. When presenting with combined hyperlipidemia, lifestyle changes contribute to a large improvement. Work on the lifestyle, be strict with them. Don't start dishing out tablets, more tablets. Get what you want rather than from the patient. That's the 34-year-old hyperlipidemia. Again, you can see the total cholesterol slightly high. He, again, has problems. I don't know what the significance of the bundle branch block there is, but he came to us with that. He's been seen by the cardiologist, and he wasn't too bothered about it. I don't know, how you feel about that. He modified his diet really well, and he used to work in the supermarket shelving, so his exercise level is very good. He had no fat. You can't count a cell of fat on him. Really can't. BMI slightly higher than you would expect. Again, we're finding it very difficult. This is not a so unfortunate. This is not a fortunate man at all. He's in and out of the hospital all the time. You can see we started with morphine fibrate, nicotinic acid. Then when tobacco became available, we tried morphine fibrate, omeprazole, and it doesn't touch more than it just clips that whatever you do, and he's already and he must have had this is earlier. So always goes into A&E and to keep them, and they find it very positive for the LDL team. So you may 100 million, so you don't have to do typing on everyone. When you fail like this, you should be of doing so from secondaries. Usually when it's so, as Dr. Puri said, there is some primary problem there which we are not able to these are all different types of criteria. That's familiar hypothesis deficiency of hypotension. The triglyceride, that's when it becomes really difficult. We may even have to advise some terms. The only I pick up as a lipidologist is pregnant women who have high triglycerides from the labor ward or from the antenatal clinic when they ring me. Otherwise, I don't have any emergency to do a stent. I never get up to this profession to do. You did that? So low fat diet, physical activity, all this is also important. But if the patient is symptomatic, you'll have to keep them on pill by mouth, IV fluids, pain control. No fat diet is not fat diet, fibrate omega-3 acid, and you can give insulin and glucose together because it increases the lipoprotein lipase activity. So, you can give somatostatins too. So this is another patient who is, it's my liver doctor, so came from the liver doctors. Xanthellus matter, palmasanthoma. What do you think this patient has? In primary biliary cirrhosis, there is a fraction in the blood which is lipoprotein X which increases. When the bilirubin goes up, the complex that forms is lipoprotein X. Lipoprotein X is not heterogenic. So if you have people who are cholestatic and have lipoprotein X, that is the reason for saying you don't have to treat them with statin. However, visit with such lipid lowering drug just to that primary biliary cirrhosis is another cause where you can have a gross hyperlipidemia. What's that? Diagnosis is there on the slide. Nephrotic. Measured albumin, I think we do 2.8, isn't it? That's per liter. So it's 4.6, 2.8, and 4.5. So that's nephrotic. So don't forget nephrotics. You don't want to miss that. Do people use Roaccutane here for acne? Maybe I should. This is very topical. 8-year-old boy with 14-year-old brother comes to your clinic with his mother who is under your care for high cholesterol level in blood, and you screen the boys. 8-year-old Ramesh's blood shows that. Sorry? Familial hypercholesterol. Louder. When you have the right answer, louder. I'm being so loud.
Familial hypercholesterol.
Good. So that other people will also know. So, that's the mother's lipid profile. Post-treatment, 200. Heterozygous effect. Grandmother had demand. What would you do, 8-year-old? What is your practice?
No, biggest good.
Pattern, and there is a study where they look at the carotid media thickness in children who have hypercholesteremia and in those with familial hypercholesteremia. And therefore, this disease starts much earlier, and it's especially if the had disease when we start from statin 20 milligrams
The drug you mentioned, I think is statin. Is it available in India? I don't think so.
Pravastatin is
In India.
not available.
Then what you would do in India, especially the maybe 15-year-old child, 12-year-old child,
Atorvastatin is fine because there were some studies in atorvastatin as well. I don't know whether the atorvastatin has license here for pediatric use. I'll have to check.
no company comes and tells us for any pediatric use, so I'm not sure whether the license is there in any case.
Beyond, but we all do things slightly differently to more complicated cases.
What dose of pravastatin do you use?
20 to 40.
20 to 40. It's quite safe and healthy.
Yeah. I mean, the studies have been done with, and I think in Netherlands they do use 10 milligrams of atorvastatin as well. Because they're the people who started treating children much younger.
They use 10 milligram atorvastatin. Any studies on rosuvastatin?
Sorry?
Any studies on rosuvastatin? No.
And just to tell you, like we all worry about the glucose, don't we? The diabetes, and if you give statin to people with the high cholesterol, the diabetes. In FH patients, the LDL receptor defect protects them somehow from hyperglycemia. So if you look at all the literature of the treated FH patients, they don't develop diabetes. The general population does. And so, you don't have to worry about that as well. I think I should stop there. Should I? I think that's it. Sorry? Omega-3 fatty acid. Omega-3 fatty acid is good for high triglycerides.
At what dose?
2 grams BD. I don't know if you have Omacor here. Maxipa, it's 6 capsules BD, isn't it? Pounds per month. So we don't use, Omacor for cardio protection. We use it to treat high triglycerides.
What is the result of analysis? What are the side effects and what is the result?
The result up to 30 to 40% reduction depending on how high the level is.
Monotherapy or combined therapy?
Monotherapy can give you 30% reduction.
Any drug interaction or side effects? What you mentioned was familiar. Actually, I was the phone calling. Do you think was it really familiar or would you have high fat diet in the family itself?
That's familiar.
How did you diagnose it?
Genetic diabetes.
You did
And the
the
mother has high
The
cholesterol.
mother may have a dietary pattern in the family is quite bad, which is happening in Delhi right now. You might just have because the eating was not really high. Before starting the statin, might have been a better idea and then wait for 3 to 6 months.
I don't think that diet plays a major role. Diet
Familiar.
only contributes to 10 to 15% of serum cholesterol.
That's triglyceride.
Triglyceride is the only protein which you can reduce by 50% with lifestyle modification. That's the only, other coming to the cholesterol and LDL, the dietary contribution is hardly 50 to 20%. We all stress upon diet. Of course, therapeutic lifestyle changes is one of the most important strategies. Whatever you do prior to giving anything. But 287 is too high for waste. For 3 months trial, say come down. Because if you give drug, bring it down, And if you think that it has come down so low with medicines, you can stop medicines anytime and more stress on lifestyle modification. But for LDL, I don't think that lifestyle modification will contribute more than 15 to 20%. Dr. Singh is from Chennai, is another great lipidologist, and I think we have
exercise plays an important role in any management, particularly for the disorders. Not only increase physical activity will help you to bring down triglycerides, as rightly pointed out. It may increase the HDL to some extent. Unless you do a vigorous exercise, you cannot anticipate any further increase in the HDL also. The LDL cholesterol may not come down in spite of the fact we regular exercise for quite some time. So, adherence to the lifestyle modification on a continuous uninterrupted basis probably will help these patients to bring down.
Very unusual. I don't think we have drop foods, but not that level. Diet never raises the cholesterol levels in children to that level. If, there is also a reverse, cascade screening in UK where they go and screen the children, which Dr. Puri has done it. There's only a small study from our centers now. Dr. Puri has done that. And that is the best way to screen familial hypercholesterolemia because children, if you pick them up with high cholesterol, they're more likely to have familial hypercholesterolemia. We adults do more harm to our body by doing wrong things than children do. They run around, even if they eat, they run around. If they eat 5 laddus or 6 laddus, nothing happens to them. They grow vertical. We grow horizontal.
One thing more to that is that absorption is not more than 15 to 20% cholesterol. It's not more than 15 to 20% because azithromycin, which is a drug which prevents cholesterol from the eye. That's the main mechanism of azithromycin. The reduction is only by 18 to 20% in all the trials. So it reduces the LDL cholesterol by 18 to 20%, not more than that. So I think that we should, go for a lifestyle changes, modification, aggressive, but we should not depend primarily on lifestyle modification, especially with a person with LDL cholesterol of 218.
Of course, with the approval of Madam as well as Dr. Puri, let me try to recollect the patients whom I have seen, the children of 12 years old and 9 years old. Both of them were brought to my clinic saying that somebody detected high blood cholesterol levels. The serum cholesterol level was about 700 milligrams in both of them. And the LDL was very high. The HDL was around 15 or 20. And then he had almost all the tendon xanthoma and the xanthelasma. And easy to make a clinical diagnosis of a family of hypercholesterolemia based on these skin manifestations. Of course, the laboratory investigations also confirmed it. Genetic screening could not be done because they were not cooperating. In fact, I had to struggle in treating these patients, but I called the parents and then wanted them. Again, they were not willing. In fact, I explained to the parent that these children are likely to die at any time because of heart attack. And you need to be very careful with these medications right away. Initially, we started only on atorvastatin 10 milligrams for both of them. They did not do well. Within the next few weeks, at the end of 3 months, I happened to see the same levels again. Then we increased the doses of atorvastatin 20 milligrams. Another 3 months, nothing happened. The same thing was persisting. I took a bold decision of starting rosuvastatin 40 milligrams for this child. And the elder sister, one evening, she suddenly died. Only one girl left with the same problem of high blood cholesterol. It started around 40 milligrams of rosuvastatin. Believe me or not, the cholesterol came down. Within a matter of 12 weeks, it came down to around 600, 500, like that it was coming down, LDL came down. The child was intelligent in the sense He came and told me even the skin lesions are trying to disappear. So we need, probably we say that probably some atherosclerotic lesion, what is seen in the coronary arteries or any vessels, probably is also mimicking the same sort of appearance even in the skin. The child was very, very intelligent to tell me that she has been improving. And now the cholesterols are maintained very well. He has no side effects after starting a 40 milligram of rosuvastatin. In fact, I was hesitating to start that much dose because none of the pediatricians gave me an assurance that she would not develop any sort of problems. In fact, I had an opportunity to have a discussion with Dr. Richard Brown, who came from the United States. He is actually the editor of the Journal of Clinical Lipidology and also president of the National Lipid Association. We were together sharing the platform. In fact, there was a question with regard to the hypercholesterolemia in children, and he wanted me not to dwell in that subject. I started narrating the story and told him that I started only with 20 milligram to start with. And I told him after a period of 12 weeks, I pushed it to 40 milligram. He said, Dr. Narasimhan, for a 2-year-old child, I am giving 40 milligram of rosuvastatin. Then I told him, sir, don't ask me evidence. Where is evidence? I will also not disturb you. Where is evidence? Our aim is to control the cholesterol. Our aim is to prevent the cardiac problem. This is the have this problem. No, still she is on 40 milligram. She is failing that, Yeah. Not there. Yes. No, this is
वो प्रोफेसर है
Ashok. This child will also like the same problem. If you allow me to start, in fact, I got everything in writing from the parents, and I was old enough to do that. And for the past 3 years, they've been good control of the cholesterol. So it's our my own experience. I'm just trying to share with you. Not that it should be propagated to the entire country. Say that we start our 40 milligram for all children with hypercholesterolemia. Not at all. It's my own experience because this madam started talking about it. I thought this would also just join and just trying to tell my personal experience.
Most
sounds of it.
sometimes we use unlicensed drugs on unlicensed medication because we want to save lives. When you save, I think the issue there is, do you want to save that life or worry about your next life?
म्यूजिक को जो टाइटल वगैरह दे दें
As a doctor, you would choose to save the life of the individual.
Medical observation, wouldn't you be in trouble that why you
मैं आपको
As a specialist, I always go with licensing.
डाउन मैं कर दूंगा मुझे लिंक भेज दें
And one thing is that trials are done only on these issues only. And what side effect do you expect with rosuvastatin? Hardly any. Dr. Narasimhan has quoted one. After these studies of 2,500 children, we had about 16 children who had an LDL cholesterol of more than 200, and majority of these children on rosuvastatin, and it's almost a year now. In our cardiology practice, we use, of course, not the children. 40 milligram is, I think, few hundreds of our patients are rosuvastatin. So I don't think that if you have a good interaction with patient and you have discussed things very clearly with the patient, you can start. And of course, I don't think these drugs will have any such a major complications that we can put in cover. And a proper good discussion with parents are important. That's all. Nothing more than that.
And it's the same like this, isn't it? A pregnant lady with a triglyceride of 1,800 or 2,000. There's no study giving fibrate to a pregnant lady. But you will give it because if the patient develops pancreatitis, the risk for the mother and the child. So you will give it just to save the lives.
start in the second trimester or when you do it?
If the triglyceride is,
They inject in the first trimester.
we have started even in the first place. We do advise after, if the triglyceride is very high in lipoprotein lipase, not to get pregnant.
why do you see that?
GPs measure triglycerides for other reasons, like they may have had increased triglycerides while being on an oral contraceptive. So they know if they are on oral contraceptive raised triglyceride, they go and measure. That's another sign. If the triglyceride is increased on oral contraceptive, pregnancy, then it will also have high triglycerides.
Thank you very much, Dr. Devish Nair. Difficult question. Even we thought that it is good for us that we are sitting here. We don't have to answer this question. And I tell you that most of you must be aware of medical tools and make sure that whatever discussions are here and whatever she has told, at least 2 questions will come from her. So I'm just giving you a hint because I want you should work hard to get first prize of 1 lakh rupees, second prize of 50,000, and third prize of 30,000. Last year only one prize went to one RML doctor. Is he there or not? Who is this? Stand up. So he is the person who got a check of 1 lakh rupees. You are very honest in reviewing the check, is that right? So, work hard, and I'm sure that this time next year the price may go up. So that is what I wanted to tell you. So we'll go for the second session now. After this.